Dr. Baker is one of my favorite progressive economists. If you read economic policy on the internet, his Beat the Press blog is one of my favorites. Highly recommend you bookmark that and read it on a regular basis. He co-founded the Center for Economic Policy and Research in 1999, and so we were just speaking, so it's the 20th anniversary. I'm sure they'll be doing some events to celebrate that. He writes a lot about really all the major kind of issues of economics and policy that are in the news these days, from trade, healthcare, patents, monopolies, all the big ticket stuff. And I think he has a lot of really interesting and important things to say about that. I asked him to come in to talk about healthcare today because I'm an environmental economist who say, well, what does healthcare have to do with anything here? Healthcare spending is really the story of long-term U.S. deficits. So even though Social Security is projected to be in deficit by about maybe 20% in about 15 or 20 years, and obviously we have a very bloated and expensive military budget, the big story of long-term U.S. deficits, though, is really a healthcare story. And Dean has done an incredible amount of thinking and research on that, so he seemed like the perfect person to come talk to us about that. Obviously, we're getting in America, since we're in a constant political cycle. We're already gearing up for 2020 now. We have two political parties in this country. We can argue about whether we should have third-party systems or not, but we only have two right now that are viable. One of them wants to solve the healthcare puzzle by taking away people's health care and taking away their benefits. We know who wants to do that. And so it's left up to the Democrats to figure out how to actually expand coverage and bring down costs. Right? So that's the story here. And so Dean is going to talk for about 20-25 minutes about healthcare, his views on that. Then we're going to sit down and follow up and expand the conversation a little bit more because he has such knowledge on such a range of topics. I thought it'd be a waste to have him come all the way out here and we just focus only on healthcare. And then we'll open it up for Q&A. And the goal is to go, use the whole time here until 7:30, and then we will call it a day. So please join me in giving a very warm honorary welcome to Dr. Dean.
Thanks, Jason. It's good to be here. Thanks, Rachel Christopherson, who made all the arrangements, which thus far have been absolutely flawless. So I'm suffering from sort of a green shock because I moved away from Washington, D.C. last summer. I'm living in southern Utah in the desert, which is very beautiful, but it's all brown. So this is quite a contrast. Very beautiful, too, but very, very different. So anyhow, I'm very happy to be here in all seriousness. Okay, so what I want to talk about is the healthcare costs and the deficit, and my main points are, first off, that the deficit is largely a healthcare story. I'm saying primarily. Obviously, you could look at the budget and say, we could do other things. Of course, if we had the tax cut, the budgets would look much better. I mean, there's no doubt about that. That's not an arguable point. You can still say tax cut are a good thing, but it costs us a lot of revenue. It's not really an arguable point. But I want to show that healthcare is a really, really big part of the picture. Basically, that our healthcare costs are way out of line with the rest of the world. And if that weren't the case, the budget would look much, much better. The second point, and this has not gotten the attention that it really deserves, healthcare costs actually have slowed dramatically in the last decade. Now, part of that is clearly the Affordable Care Act. This is, Jason and I were talking about this a minute ago, that here you have Donald Trump as president who takes credit for the sun rising. Obama actually did things, and he doesn't take credit. Now, as I'll say, I'm not going to say the slowdown was all due to the Affordable Care Act, but clearly it was part of it. And what I tell Obama's people, I go, suppose it had gone the other way? You don't think the Republicans would be screaming bloody murder? In other words, the healthcare costs had accelerated? But I never heard him or people's administration take credit for that. The third point, and this really is crucial, that the reason healthcare costs are so high in the U.S. is that we pay twice as much for everything. It's not that we get anything better. I should qualify that a little bit. It's not that we typically get things better. So you could, if I have any healthcare specialist, I'm sure you could point to something that's better in the United States than in France or Germany. But if you look at it as a whole, our healthcare system is certainly not better than the systems in Germany, France, other wealthy countries. And what that means is we're just paying too much for it. So our doctors get paid twice as much as doctors in other rich countries. Prescription drugs. We're the only country we give companies patents and we say, patent monopolies, charge whatever you feel like. No one else does that. And of course, our private insurers, for most people, of course, certainly if you're below Medicare age, you are getting insurance through the private sector. The insurers, the administrative expenses are a huge, huge expense and largely a waste. It doesn't have to be there. Okay, so the first point, just showing what the world could look like if we had German healthcare costs. This might look a little weird to you. The negative indicates a deficit, so these are annual budget deficits, expressed as a percent of GDP. And you see that our annual deficit, we're starting at 4% GDP this year, rises to around 5, 5.5, 6, and then it starts to explode about 228, 229. The reason for the explosion is essentially interest costs. So what's going on there is that as we get larger deficits, we accumulate larger debts, the interest on the debt means larger deficits, et cetera, et cetera. So that's why it explodes, and it gets up the last year in projections, 248, it's almost 10% of GDP. By the way, these are from the Congressional Budget Office, so they aren't my numbers, they're from the Congressional Budget Office. They have a publication, long-term budget, something like that. It's not the exact long-term budget, that's where it comes from. So then I said, okay, let's do the same story and imagine that we had German healthcare costs. So we paid the same amount per person as they did in Germany. And that continues, so we have a constant ratio. Their healthcare costs, I forget that exact number, but I think it's about 54, 55% that we pay per person. I think Germany, it's actually one of the more expensive ones. It's not the most expensive after the US. I think Switzerland is number 2. But there are many that are cheaper. So the example, if I pick the UK, it'd be about 40%, 41% of US healthcare costs. So I wasn't cherry picking. I didn't pick Germany because they were low. It's quite the other way around. Okay, so in that story, the deficits go to 0. We begin to accumulate surpluses. 2041, we have surpluses. We paid off the national debt by 2044, and we begin to accumulate assets. So instead of having this huge rising debt to GDP ratio, we're actually accumulating assets. This was, if you go back to the old days, I've got a few people who are old enough to remember this. Back in 2000, when we were running budget surpluses, Alan Greenspan testified before Congress. He was worried that we were going to pay off the debt too quickly. So, if we have Greenspan still around in 2044 and we had German costs, he'd be having the same fears. Obviously, this is not going to happen. But, and this actually understates the differences because I'm assuming that the interest rate itself is not affected by debts or deficits. That, again, people have exaggerated how much deficit affects the interest rate, but I'd say it's not 0. So that's how it affects us here. And also, part of the story is that in terms of our healthcare costs, one of the things that doesn't get mentioned often is that we pay a lot for healthcare indirectly. The government, I should say, pays a lot for healthcare indirectly through the tax deduction for employer-paid healthcare insurance. So a lot of people miss that one. You have a lot of people say, I pay for my own healthcare insurance because their employer pays for it for them. Well, that's not entirely true because the government you aren't paying taxes on that. So, if you have someone's in a 20% bracket and then you have the Social Security taxes, they're not paying that either. So you're talking about the government paying around 30% of those premiums. So that comes to around $110 billion a year, a bit more than 0.5% of GDP. I didn't count that, so that would obviously be much lower if you envision us paying German healthcare costs. Okay, long and short, if we paid healthcare costs like Germany or any other wealthy country, and we envision that carrying that out, we wouldn't be worried at all about the deficit. Okay, the second point slowed sharply. Again, this is, as I say, to me kind of astounding that it hasn't gotten more attention because obviously healthcare has been very much front and center in the national debate. And the cost slowing is very dramatic. So healthcare cost spending per person was rising 6.8% annually, 1990 to 2008. We've been even larger. Again, I'm not cherry picking, so if I went back to the 80s, we've been even larger. And 4.7% annually in the years 2008 to 2018. So that's really quite a rapid slowdown. Now, these are both nominal numbers. Inflation was a little higher in the period 1990 to 2008, but not much. I mean, you're talking about a couple tenths of percentage points. So this is a slowdown in real spending. And it's a big factor in small and projected deficits. So actually, again, this is something that Obama's people didn't really take much credit for, that the deficits were actually smaller than was projected in most years of the administration. So, every year the Congressional Budget Office makes its projections for what the deficit will be. I won't say I haven't gone back to check year by year, but for the most part, those came in lower than projected. Again, he doesn't necessarily deserve credit for it, but what I always say is if it had been the other way, if the deficit had come in higher, well, we would have heard people screaming. And some of these changes are dramatic. The projected shortfall in Medicare. Every year, the Medicare, Social Security does this too, they come out at the same time. The trustees for Medicare and Social Security issue their report each year. It's supposed to be in March, and they keep lagging. I think last year it came out in July or something. But in any case, they come out with their reports each year, the trustees of the program. And part of that story is they project what the shortfall will be. It was 3.88% of the payroll in 2009. It dropped to 0.82%. Okay, 3.88 is fairly big, so I'm one who always likes to go, oh, we can handle it. Well, you can handle that, but that would require serious tax increases. 0.82%, well, that's not that big a deal. Again, that's not trivial. I'm not going to say it's altogether trivial, but that's something that's very, very manageable. And again, he took very little credit for that. Now, I have to say, part of that was he actually did raise taxes. So he raised the Medicare. There used to be a cap on the Medicare tax. You didn't pay it. Social Security has a cap on the tax. It's $129,000, $130,000. I should know exactly what the number is, something like that. That used to apply for the Medicare tax as well. He took that off. Okay, so he did actually raise taxes, but a big part of this was that you had much slower growth in the spending as well. So you went from what looked to be a fairly large shortfall to one that was very, very small. Again, this is one of these things, I've done a huge amount of work on Social Security, so I've more often focused on that side. So when the trustees report comes out every year, they look at the Social Security shortfall and they go, oh my God, look at this, it's currently something like 2.2% of payroll. Okay, well that's, you can argue whether it's big or small, but if you combine Medicare and Social Security, the combined shortfall is way less today than it was 10 years ago. But that's gotten virtually no attention. And again, it's kind of mind-boggling to me, I always say. Again, if it had gone the other way, instead of going down from 3.88 to 0.82, suppose it had gone up 3 percentage points, suppose it was 6.88. Well, I think we'd have a lot of people yelling and screaming. He got zero credit for that, and part of it was, as I say, he didn't take it. The slowdown in growth, again, I think the Affordable Care Act was part of the story here. It did have all sorts of cost control mechanisms, and people debated how effective they are. It's hard to believe they were not effective at all, but the fact is, healthcare costs have slowed dramatically worldwide. So, again, I'm not cherry picking here. I could have found some cases where it wasn't true, but here's just a few cases. Spain, 6.9% growth in the period 90 to 2008, falls to 2.8%. Netherlands 5.9 to 3.4. France 5.5 to 3.2. So the U.S. isn't it certainly is not unique in seeing a big slowdown. Clearly, there's something going on in healthcare. I don't know enough about specifics healthcare delivery and all the factors that go into this, but there has been a slowdown more generally. But also, I point out here, there is a history of overstating healthcare cost growth that goes way back. When I first came to Washington, I remember there was something called generational accounting, which thankfully seems to have disappeared. But at that time, it was really in its heyday. This was like 92, 93, 94. The Bush administration actually included this in the official budget. And what this was supposed to be is what share of people's income did they pay in taxes by generation, so by birth cohort. So if you were born in 1940, what percent of your lifetime income would you pay in taxes if you were born in 1950? And then it had all future generations, so people yet to be born. And that was kind of the focus. And at that time, the first one that came out, I think it was 91, 92, it had the all future generations, their lifetime tax burden was going to be 95%. So you kind of scratch your finger and go, oh my God, you're going to pay 95. That's really, really scary. Now, there are a lot of assumptions in there that were pretty dubious, and you can easily take issue with them. But the biggest part of that story, insofar as it was substantive, was this projection of healthcare cost growth. It projected that by 2020, healthcare costs in the U.S. would be 22.7% of GDP. By 2030, they would be up to 30% of GDP. And with the government paying, somewhere around half of all healthcare costs, that is a huge burden on government spending. So you get this deficit story, you get this massive, massive deficit story. So it was one of these things that you go, okay, I don't know whether that's true or not. Obviously, I'm here in 1992. I don't know what the world looks like in 2030. But the point was, you're talking about an explosion of healthcare costs. So let's say we shut down the government programs. What are kids going to do? How are they going to pay? I mean, we don't get rid of the problem. We get rid of the government paying for it. The problem is healthcare. But as it turned out, as I say, I mean, obviously 18.4% GDP is a lot of money. That's what we're projecting out for 2020. But it's a lot less than 22.7. Okay, a difference of 4.3 percentage points of GDP. It's about $860 billion a year in today's economy. So that's a lot of money. Okay, that's a very, very big chunk of money. That would be about 20% of the current budget. So that would add a lot to the budget deficit and make a very, very big difference. So anyhow, we've had this history, and again, it's one of these things that I just find surprising that, I mean, we could be out here 10 years from now, maybe it'll turn out the growth is higher than expected, but the fact is that the history has been that the projections have hugely overstated healthcare cost growth. So. Okay, the other point, the Medicare spending, I probably should have used, I'm often sensitive, I'm sensitive to where I put my axes, so people sometimes jump on you if you put an axis at, say I had 2 as the 2% of GDP is the bottom rather than 0. Long and short, that the gap has risen between the projection and the actual, so that we're now looking at the difference between projected spending on Medicare and actual spending of about 0.5 percentage point of GDP. So in other words, if the Congressional Budget Office had been exactly right, we would be spending about another $100 billion this year on Medicare, $100 billion more than what we're actually spent. Okay, so that's a big difference. And again, this just gets back to that point that, for whatever reason, Obama's people never thought to take credit for this. I don't know why. I know that some of the people, and I'd raise it, and I never got a good answer from any of them, so I don't really understand why they don't want to take credit for it. It's a large difference. Okay, so source of excess costs. Okay, I'll start with doctors. It's kind of funny. I've gotten doctors really pissed at me. I write out a lot of different things, and for example, Jason and I were talking in one of the big things. I'm a fan of financial transactions taxes. Jason's father is also a big fan of it. He just wrote a piece on it. So I'm a big fan of financial. So needless to say, that doesn't ingratiate me to Wall Street people. But I've never gotten as hostile reaction as to my writings on doctors. And I remember in particular, I wrote a piece for Politico about doctors getting paid too much in the United States. And it was originally, digressing a little bit, but I think it's kind of funny. It was originally supposed to be a fairly short piece, like 800 words or something. So I just laid out the basic argument. And then I said, oh, could you mention this, could you mention that, could you mention that? And the final piece might have been 2,500 words or something. It's considerably longer in any case. And, one of the things that, I would say, if doctors are paid less in the U.S., you'd want to do something about the cost of med school. I didn't say that in this piece because it was originally a much shorter piece. So I added all these things into it. I'd written it at the beginning, 2,500 words. I always said something, yeah, medical school's really expensive, we should do something about that. But I didn't, and as a result of that, I had all these doctors writing saying, I came out with $250,300 in debt and blah, blah, blah. And, I'm sort of glad I didn't do it, because I just figured out what the hell, I'll promote that. But anyhow, I have this as the last item here. But, okay, starting at the beginning, our doctors are paid much more than anywhere else. And it is, it was striking to me, the response, and maybe it shouldn't have been, that, I'm saying, look, our auto workers don't get paid more than auto workers in Germany and France. They probably get less, in fact, by most measures I could see. Retail workers, again, they don't get more, they probably get less. And they're comparable, we'll just say. But our doctors get paid twice as much. And why is that? Why should they be? And, I don't see a good explanation for that. I can't see a good explanation for it. So our doctors, the general practitioners, get around $200,000 a year on average. These are net of their malpractice fee. All of them jumped up and down. What about our malpractice? This is net. This is, what in principle, not they take them after taxes, but after their expenses. None of this is done perfectly. You never get exactly what you want. But the people doing the surveys try to get net numbers. So our doctors get paid around $200,000 a year. Other wealthy countries, around $100,000 as general practitioners. Our specialists get over $250,000, many of them cardiologists, like $450 on average. Other countries, like around $150. And we also, we have twice as many specialists as general practitioners, and in most other countries it's pretty much the other way. And again, this gets down to quality that you could say, oh, well, but you're seeing a cardiologist, you're seeing, you know, a neurosurgeon or this and that. Well, you go, okay, but we care about outcomes. Okay, so if your general practitioner could, you know, diagnose your heart condition, that's fine. You know, if they could do it correctly and prescribe treatment, that's fine. That's what we care about. We don't care that you saw a cardiologist, we care that you saw a doctor who knew what they were doing. Okay, and the evidence is that, at least in most areas, they have comparable outcomes. If you have a heart condition in France, if you have a heart condition in Germany, you're going to do as well in general as in the US. So we don't get anything for that. So, you know, I just say, what are the averages? We pay twice as much as they do. Okay, how can you fix that? Well, we have incredible barriers to entry in the US. So as we've done everything we could to make it as easy as possible to import steel or clothes or cars from Europe, from China, from whatever country, we have done almost nothing to remove barriers to foreign doctors practicing in the US. In fact, in some ways, we've increased them. Okay, so what we could do is say, okay, these are countries that have comparable systems, you know, so a doctor trained in Germany, a doctor trained in France, if they've gone through their program, they can come to the US and practice just like someone who did their work in San Francisco. Okay? That would be a really good thing to do, in my opinion. Medical travel. My new home state of Utah, we now have medical travel. Not from any ideological cause, they want to save money. They pay people on their public health care insurance to go to Mexico to get drugs. And I don't mean illegal drugs. People might do that, but they don't get paid by the government. So that'd be another way to, you know, get around what I call the doctor's cartel here. Increased use of lower paid professionals. A number of states, nurse practitioners can prescribe medicines without a doctor's supervision. There's no evidence that this leads to poor prescription choices, abuses, at least no more so than with doctors. There are other, you know, healthcare professionals, physicians, assistants, increase their scope of practice, you know, at least where it's demonstrated that there's not a reason to have a doctor, you know, again, that can reduce cost. And yeah, here's my concession, you know, free or low cost med school, so if you look to the European countries, it's either very low cost or in many cases altogether free, and you don't have to worry then about the issue of 250,000, 300,000 in debt. The point I will add on that, if you just do your arithmetic, say doctors a 30, 35-year career, what's 300,000 over a 30, 35-year career, you know, 10,000 a year. I understand there's interest, but I'm just, you know, if you're making twice as much as everyone else, that doesn't qualitatively change the picture. Okay, second cost, excess cost drug prices. As I said, we're the only country in the world. We give you a patent monopoly on a cancer drug or a Sovaldi hepatitis C drug. In many cases, it might be the only effective treatment. Charge whatever you feel like it. Every other country, they negotiate prices. They have price controls, however you want to call it. So they don't let you just charge whatever you want. And as a result of that, they pay not as much on average. And that's a huge, huge difference. I could go on a great length here. Well, just, you know, what can we do? Obviously, the most obvious one to do what everyone else does, negotiate drug prices. So, you know, we could do that. A number of people in Congress have talked about that. Even Donald Trump talked about that. He doesn't seem too serious about it, but during his campaign, he talked about it. He's a great negotiator, so he's going to drive hard bargains, but we haven't heard much about that lately. Antitrust policy with generics. I mean, this is a story that got a lot of press. It's not a big chunk of our drug spending. We spend a little more than 20% of what we spend on drugs is for generic drugs. They're about 80% of the drugs you get, but about 20% of the spending. But you do have the cases, EpiPen, insulin. I mean, these are old drugs that, you know, there's just no excuse for them to be high priced. And basically, the Federal Trade Commission has just abandoned antitrust policy. Shikeli got all this press, the pharma grow. I mean, that was a story, it was just classic antitrust. I mean, the guy's a genius. He figured out that, you know, you have these drugs that have very limited markets. You know, he's able to get control of basically the whole market. And they were important drugs, but very limited markets. They're generics. And he jacked up the price tenfold, 20-fold, 100-fold. And people had no choice because these are important drugs for the people that had them. It might just be 7,000 people, but for that 7,000 people, they need those drugs, so they had to pay the price. This is the sort of thing that, you know, the FTC should never have allowed. And Elizabeth Warren and Jan Schakowsky, Congresswoman from the Chicago area, she used to be my mother's congresswoman, but they proposed having a government manufacturing facility. So if they saw this, they would be prepared. They'd contract out, so you don't have to worry about the government taking over the drug manufacturing. They would contract out, but the point was, if you had a Shirkelly come up there, they could very quickly step in there and undermine them and make it available at a generic price. My ultimate solution is pay for the research up front. And yeah, this is, to my view, it just, I mean, I have had other economists, other people say, oh yeah, it's a reasonable thing to do. But just, to my view, it's absolutely crazy that here it is, we rely on patent monopolies to finance the research. I make the analogy here, it's like, if we pay our firefighters when they came to your burning house with your family inside, and they go, well, is it worth $1 million to save them? I mean, no one thinks that makes sense, but somehow with drugs, we think that makes sense. That, here it is, you have hepatitis C, well, do you want to live? That'll cost you $80,000. Well, yeah, I mean, it is a worthy life. But on the other hand, this is a drug that costs $200-300. We know that because the generic version is available in India, and it's a high quality drug. I mean, India's generics are, in fact, many of our companies contract out with those companies. So you go, oh, I don't want India. Well, too bad for you, because odds are there's a decent chance that drugs you're getting are made in India by those same companies. So, my view, pay for the research up front, have long-term contracts, and then have everything be in the public domain. And, instead of paying $440 billion a year in drugs, my rough estimate would probably pay about $80 billion a year. Drugs would be cheap, because they almost invariably are cheap to produce. Okay, third source of excess costs are insurance. This is what we pay for private insurance, healthcare insurance that most people aren't on Medicare and Medicaid have. It's about $230 billion a year in administrative expenses, so about 1.2% of GDP. It's about 19% of what gets paid out in benefits. So, if you think of, okay, you had 5,000 last year in healthcare expenses, well, roughly a fifth of that, 1,000, was simply going to pay the administrative costs of insurers. Our Medicare system, the administrative expense, is around 2%. It's roughly the same for Canada, 2.5%, something like that. So we have a pretty good basis for saying what the expenses would be if we had sort of a Medicare for all system, a universal Medicare system. This almost certainly understates the expense because insurers require that hospitals and providers that they have staff to deal with the bills. So, if you go in a doctor's office, a hospital, of course, you have the people who are actually providing health care, the doctors, the nurses, physicians, assistants, all the other people who actually provide health care. And then you have a whole administrative staff that have to deal with this billing, which if you envision we had a single, Medicare system or whatever you want to call it, a universal system, you would need very minimal staff to deal with the bill. Because all these issues end up being very complex. They all have different types of coverage, different co-pays, deductibles. It ends up being very complex, and invariably they make mistakes. So then you have people calling in going, "Oh, you didn't, this wasn't billed right," and this happens all the time. It's inevitable. That something wasn't billed right, and then someone's stuck with a $5,000 bill, and the insurance company is supposed to pick it up. So it requires a lot of staff, and of course it's a pain for the people. I mean, again, it's one of these things like, when do you want people to have to deal with this? It isn't, who has high health care bills? Well, people who are in bad health. So you don't want them to have to fight with insurers, and the system we have leads them to have to fight with insurers. So it's both very expensive and very counterproductive from the standpoint of providing people with good health care, because at the time where, they're most worst shape, I should say, they or their family members have to struggle to deal with these bills. That's not the situation you want. Okay, solutions, well, universal Medicare, Medicare for all, would be great. We have several candidates, most obviously Bernie Sanders, but other candidates have also endorsed Medicare for all. Kamala Harris has. I'm not sure exactly what it means for her. I mean, not to deride it, it means different people use the term differently. I mean, we know Bernie Sanders because he's been saying it for God knows how long, but it's come to mean different things to different people. But in any case, that's something that's now on the agenda. I have to say, I don't think, even if Bernie Sanders ends up in the White House in 2021, I don't think we're going to see Medicare for all, at least not right away. So, but that'd be one way to get down those costs. The other, Medicare buy-in option. Others have talked about that. That you could allow people who are under age 65 to buy into Medicare. You could also gradually lower the age. access. Again, something a lot of people have proposed that lower the age to 60 or 55 or whatever. So you get more people in the Medicare system, reducing the number of people who are dependent on private insurers. So there are ways to get down those costs, but the idea that we're going to get rid of the private insurance system in some short period of time, I don't think is very plausible. But we can talk about ways to reduce the cost. And part of the story too is if you had competition, if you had a buy-in option that was available to people and was a good option, then it puts a lot of pressure on the insurers to basically straighten up their act and get their costs under control and provide better service. So I think that's, to my view, that's a very, very good prospect. Okay, so to sum up, first off, as I say, if our healthcare costs look like those in any other country, our deficits would be nothing to worry about. Secondly, that the costs have been constrained in the past, so people want to jump up and down and go, oh, we can never do anything. Well, we have. Again, how much of that was due to conscious policy versus how much was due to good luck, who the hell knows? But we've had success in reducing cost growth, so it can be done. Hopefully it can be done in the future. And the last point, anyone spend enough time in Washington. These are all really, really powerful lobbyists. I was once saying something, I said, well, it should be simple. And this other economist, Henry Aaron, has been in Washington forever. He said, being in Washington, nothing's simple. And that's right. And these things are all really big things. So they would be very, very hard to do. But the first point is to understand what the problem is, and then you figure out how to go about the right. Thank you.
All right. Well, one thing about the healthcare issue that it's kind of like a lot of other issues that I focus on as an environmental economist. Things are so bad that at least there's a lot of things to help fix it, right? Like I said, that with water policy, like we do so much to waste water in every possible way that at least there's a lot of yeah, right. There's a lot of ways, solutions. So you certainly outlined a bunch of them. I'd like to follow up on this issue of the public funding of research directly. When I taught international economics, I used a figure, and this is a little dated, about 10 years ago. Someone added up all the foreign aid money that OECD wealthy countries have transferred to Latin America, Asia, Africa, and it was somewhere on the order of $3 trillion over, post-World War II. And it's probably an underestimate if you look at adding all kind of military and stuff like that. So I thought to myself, I said, what do we get for $3 trillion? And I thought, wow, if even a tiny fraction of that could go into basic R&D for malaria and all these kind of tropical diseases, and we had just given this up for free, that would have been a much better international development, probably, path. So I guess the point is, what is the path forward for this? Are there countries that are doing this? How feasible is this? Is there something to fear about losing some edge in innovation that maybe private industry does better than government? Just talk a little bit more about that.
Well, a few things. There's no country that really looks to finance drugs from their beginning through their fruition, as a matter of policy. There are some instances where it's been done, but that's not been a matter of policy. So, in fact, we've done that. So AZT, the first AIDS drug, was developed as a cancer drug on NIH funding. Now, the research to see that it was successful, wasn't a successful cancer drug, but to see that it was successful for treating AIDS, that was done by Burroughs Wellcome, also with a lot of NIH funding, as you point out. But in any case, that was done by the private sector. But you do have examples where we have developed drugs through the public sector. In terms of the sort of advanced funding system, probably the best example is the Drugs for Neglected Diseases Initiative, which is being done by Doctors Without Borders. And they've developed a number of treatments, mostly of existing drugs, but they actually have developed some new drugs. And their total spending, I haven't looked at it lately, but it's somewhere in the order of $1 billion over, at this point, maybe about 15 years. And they've developed a number of treatments, 1 or 2 actual new drugs, new compounds. And by comparison, the industry claims that it costs them $2.5 billion to develop a single drug. So they have a pretty good record, and a lot of people have benefited from that. Now, the way I would propose going the other route is, again, not envisioning that you're going to have a replacement of the patent system overnight. So doing it in competition and focusing on some limited number of disease areas. So suppose you parceled out, say 15 billion a year, just to give you a frame of reference.
Currently, the National Institutes of Health gets about $40 billion a year. There's probably another $1 or $2 billion in research dollars going to Centers for Disease Control and other agencies. But figure $40 billion roughly is the government's spending on biomedical research, and the industry claims it does about $70 billion. Okay, so those are kind of the general parameters. Suppose you said we're going to take $10 billion, $15 billion a year, and we're going to parcel it out to go for cancer research, go for heart disease. I don't know, 2 or 3 areas. You won't make it illegal for Pfizer and Merck and the rest to go ahead and do research, but they're going to know that they're developing their drugs, and they exaggerate the cost of research and development, but nonetheless it is substantial. They may face the risk that come 10 or 15 years down the road, they're going to be competing with a cancer drug that's selling for $300 a treatment instead of $300,000. So that will discourage it. But if they want to do it, and I argue with industry people and they go, oh, we'd be throwing money in the toilet. I go, fine, what do you care? Let us keep going. Obviously you don't think of you throwing money in the toilet. So, my view is you would contract it out, and you would have long-term contracts. I use the Pentagon as an example here, where government contracts with the Pentagon, sure, there's a lot of waste, but the reality is, whether we like it or not, we do have very good weapon systems. So it does work, and the big advantage you would have in biomedical research over military research is everything would be in public. We actually have good reasons for secrecy with military research. I mean, they exaggerate it, but nonetheless, it doesn't make sense to put our latest weapon system online so Al-Qaeda could download it. That's right. Whereas with biomedical research, condition getting the money, it gets online as soon as possible. When we had the Human Genome Project, it's something called the Bermuda Principles. Everything got posted nightly. Now, whether that's feasible or not, I don't know, but the point would be timely. So you have to go quickly, so all research results are available to other researchers, and if you have some great innovation, other researchers could take off on that. If you made some big mistake, it's on the web, so other researchers go, hey, you don't want to go that way. So that's how we look to go, and I think you could phase in, and again, if it works, then obviously people want to expand it. I mean, I was at a conference and I said, how you decide the disease areas, and I'm not an expert in the science. You need people who are expert in science to decide what makes the most sense. But they said, well, but then everyone will be lobbying for you. Go, it's okay by me.
Yeah, I always joke that there's more money going into baldness cures than into a lot of the tropical diseases, and I'm actually not looking for a baldness cure, but I would love to see a cure for tropical diseases. But they're just, if it's a poor person's drug, there's no incentive, and whereas if you had public funding, you could actually have social benefit be the metric, right? What's going to benefit the most people and help society, not just where can you make the most money. And that seems like a better way to innovate on drugs.
Yeah, and where you have people saying, well, I am very concerned about baldness. I'm going to have an issue there too, but whatever. I wouldn't argue it should be a major research priority, but okay, so if people are willing to pay lots of money and the government isn't, well, you're not going to arrest anyone for doing it, so they can go ahead and do it. So that's the thing. So you'd be allocating funds for this area, this disease area, that disease area, that disease area. Is there one that's neglected? Well, go ahead and do it. We haven't taken away anyone's right to do the research, get a patent, sell it for whatever. If they want to charge $100,000 for baldness treatments and people are prepared to pay it, that's not going to bother me terribly.
Right. Yeah. Just to put this in context, one thing I always applauded the second Bush administration for was the money they had spent for AIDS drugs that they gave to sub-Saharan Africa, and I think that was order of $10 to $15 billion. So we have experience of those type of investments in drugs, and so putting it into cancer research or something, it seems like a no-brainer. Is there any candidates that are talking about this that you're advising?
Well, Warren's people have been interested in this. Bernie Sanders has actually proposed legislation along these lines. So I don't know if he's included this as part of his platform for 2020. I've been looking at his website. But when he was in Congress, both in the House and Senate, he proposed legislation that would have public funding for research. And just to be clear, because I tweeted on this, and someone's going, well, who would pay for their testing? Bringing through the if that would be included. So you would have you'd parcel out these contracts, and the point would be, you would do the research, you develop the drug, you bring it through the FDA approval process. I understand it all costs money, and that money would all be available in the public.
Yeah. So let's change topics here. We have a lot of people interested in international trade and development here, and you've done a lot of writing on the issue of kind of outsourcing and especially China's impact on kind of manufacturing in the Northeast and Midwest. And you've been one of the economists on the left who's really criticized, I think, other people on the left for kind of minimizing the impact that you think a lot of these trade deals really did have on the manufacturing class, the kind of what's called the kind of the blue collar white working class in America. You've done some estimates of millions of jobs in the early aughts that were lost. Now, so that with that being said, and maybe if you want, you could talk a little bit about your work on that. But the interesting thing is now the response to that now isn't to put tariffs, right? You probably wouldn't suggest that now putting tariffs on China is the way to get those jobs back. Sometimes you can't reverse course it. So maybe you can talk a little bit about what you think those damages were to the manufacturing employment here, and then if we are going to do a coherent response to China, what could maybe bring some of those jobs back to the U.S.?
Yeah, well, the basic story, this has been really such a frustration to me because I really think it's about an incredible dishonesty in the profession, the economics profession. We had a massive increase in our trade deficit between 2000 and 2007, and that corresponded to a loss of roughly 3 million manufacturing jobs, roughly 20% of all manufacturing jobs. There isn't much ambiguity there. We didn't lose manufacturing jobs like that in years past, and you could go back, and I have gone back, it's very simple. If you go back from the early 70s to 2000, there's very little change in the number of manufacturing jobs. There's up and down cyclically, but there's, the difference, I randomly picked December 2000, went back 30 years, December 1970, we lost like 200,000 jobs over that period. So about 2% of manufacturing jobs over 30 years. Now you have people say, oh, the reason we lost jobs in manufacturing was productivity growth. Well, we didn't lose jobs in manufacturing because of productivity growth in 1970 2000. There was plenty of productivity growth over that period. Basically, the story there was that increases in demand roughly offset the loss of jobs to productivity. So to tell you a simple story, so if we could produce productivity growth in the auto industry rises by 2% one year to the next year, but we sell 2% more cars, well, you need just as many workers. Now, that means you may not have fit for the auto industry, but it did fit for manufacturing as a whole from 1970 to 2000. Suddenly, we lose 3 million jobs, and I'm picking 2007 as an endpoint deliberately because that's before the recession. So this was not due to the Great Recession. This predates the Great Recession. Okay, so that was trade. That seemed very clear to me, trade. And that was a devastating hit for manufacturing workers and communities across the Midwest, Northeast, places that Donald Trump carried in 2016. You could argue whether that was causal. I'm not a political scientist. I know there's a big debate how much of this was, racism, sexism, versus how much was economic, hardship. But the fact was, he carried these states that had previously gone Democratic twice, for President Obama. In the case of Pennsylvania, had been Democratic, I think, since the last time I went Republican was 1984. So these have been safely Democratic states in several cases, and they flipped over and voted Republican. These were states that were very, very hard hit by job loss, and the overwhelming factor was China. It wasn't just China we had a trade deficit with and we lost jobs too. That was, far and away, the largest single source. And again, I try to point out it wasn't the only one because a lot of people want to beat up on China and this and that. China was a very big factor. It wasn't the only source, but that was clearly a very, very big factor. And of course, the big thing with China was admitted to WTO in 2000. And that basically opened up our market to China, and they took advantage of it very aggressively. And so that was the story, and it devastated these communities, devastated manufacturing. You saw a very big hit to unions in manufacturing. Unionization rate of manufacturing just plummeted. It's still slightly above the overall average, but not by much. It's about 9% today. It's not exact figure, but it's roughly 9%. It had been around 14 or 15% if you go back to 2000. So a very big hit to those areas. Now, can we bring those back? No. I mean, this is a one-time story. The factories have been shut down, the workforce has been scattered. Suppose we put up big tariffs against China. We put up some tariffs, they can get bigger. We can put up tariffs against other countries. Those jobs aren't coming back. And one of the things that, I'm not happy about, but it's reality,
As we've added some number of manufacturing jobs in the recovery, the number of union workers in manufacturing has actually continued to fall. And I think it rose a little bit 2017 to 2018, but if you compare 2018 to the trough of the recession in 2010, fewer unionized manufacturing workers than there were in 2010. And wages in manufacturing have fallen relative to wages in the economy as a whole. So it's no longer the story. I mean, you could tell the story that go back to 2000. These were good paying jobs for workers without college degrees, workers with less education. That's not especially true. I still think it'd be good to get more manufacturing jobs back, it'd be good to have more balanced trade. There's other factors there, you know, part of the story, we were talking about this earlier, part of the story, you know, people are saying, well, we could run large budget deficits today, doesn't seem to create a problem with interest rates. Well, part of that story is that because we have a large trade deficit, you know, so suppose we had a smaller trade deficit. Well, my way of getting a smaller trade deficit, you know, if Donald Trump calls me up and says, hey, I want you on my team, I would focus on currency. You know, he actually ran around the country when he was campaigning 2015, 2016. He's yelling, China's a world-class currency manipulator. When I get in there, I'm going to declare them a currency manipulator day one. Blah, blah, blah. Well, probably that was racist, but they did definitely keep the value of their currency down. Everyone acknowledges that for the last decade. They do it retroactively. They didn't at the time, but you know they do acknowledge that. They're buying up hundreds of billions of dollars a year. I would say they're still keeping the value of their currency down because they hold around $4 trillion in reserves and kind of their sovereign wealth fund. And that's very high relative to their GDP. They should hold perhaps a third or fourth consistent with what other countries hold. And that keeps down the value of their currency. Again, I've had to argue this with a lot of economists. They look at me kind of blank-faced. They go, well, the Fed holds trillions of dollars of assets. Is that keeping down interest rates? I go, yeah, same story. Just change the labels. So the fact that China's holding somewhere around $4 trillion in reserves, that increases the demand for dollars relative to the situation where, let's say, they have $1 trillion, which means that it keeps up the value of the dollar relative to their currency. So my focus would be getting the value of the currency down. One of the things that's become front and center, and even people like Paul Krugman is a friend, and I mostly agree with him on that, but I'm holding him up as a very mainstream economist. They'll say, oh, we do have a legitimate issue with China that they steal our technology. I like the R, because they haven't stolen my technology. So the story that we're supposed to be upset about is if Boeing wants to set up shop in China, they're going to require, Chinese government is going to require they take a domestic company as a partner. And the issue then is that the domestic company will learn some of Boeing's technology, and then 3-5 years down the road, they're going to be a competitor. Maybe not building a full plane, but maybe they'll build an engine or some major component of the plane. So that's what we're supposed to be upset about. Well, I'm not particularly upset about that because it doesn't bother me that China's, developing very rapidly. They have a huge middle class now. I mean, that's a very, very good story. But the other part of the story, I have to tell my friends who are upset about outsourcing, or you don't like outsourcing, that's pro-outsourcing. Because when is Boeing going to be more likely to go to China if they could go there and have to worry that they were required to transfer their technology and get a new competitor, or if they can go there and say, hey, you don't get to see any of it, we're not taking a partner. It's going to make them more likely to outsource. So that would not be my priority. I would not be yelling about that. So I would focus on currency, currency, currency. I mean, there's other issues, but I mean, that would be my priority.
Thank you. So I got two last questions here before we open it up. One here is on the environment, because I chair an environmental policy program, and I figure I would be remiss to not ask you one question about this. You were having a debate back and forth on your Beat the Press blog with someone talking about how, if we're going to take climate change seriously and really make the investments and decarbonize the economy, you were making the theoretical point that this doesn't necessarily mean we have to give up economic growth, right? If economic growth is in renewables and information technology, we can still see economic growth while we decarbonize. And the person who was kind of arguing with you was kind of taking his ass, saying that's probably not going to happen, that's theoretical, in practice that's probably not going to happen, and if by telling people that we can have it all, that we can have economic growth and decarbonize, we're kind of selling a false set of goods, so to speak, and we have to get people ready for the fact that climate change is going to demand a change from the kind of perpetual economic growth. I think I'm paraphrasing it reasonably well. Could you talk maybe your final thoughts on that? And I do urge people who are environmentalists to go read that whole exchange.
Yeah, well, I guess I put it as a near-term and a longer-term story. So the near-term, clearly we have to do a lot, and we have to do it quickly to try to reduce our greenhouse gas emissions. I don't think there's any reason that can't be done while sustaining very good economic growth. I mean, China's actually a great example. China's had very rapid economic growth. China now has, they're going to produce more electric powered cars this year than the rest of the world combined. They have more solar capacity than the rest of the world combined. They have more wind, or almost as much. Someone correct me on this. I mean, you have to go and double check that. They have almost as much wind capacity as the rest of the world combined. China's been growing rapidly, but it's still, even now, a relatively poor country. Its per capita income's 1/3 what ours is. If they can make that sort of change that quickly, it's a little hard for me to believe that we can't have very substantial reductions in greenhouse gases while still maintaining strong growth. And part of the story, you can see it almost as a benefit, that's we are so incredibly wasteful now that there's so many things that can be done that will bring about substantial emissions reductions at relatively low cost. Just take an obvious one, weatherizing homes. I mean, so many people have, I moved in an old house in DC a decade or so ago, and we put insulation in our attic. It cost us, I don't know, maybe $1,000, and cut our heating bills in half. So probably paid for itself in 2 years. Very, very simple things, So I don't see that as a near-term story. Now, longer term, can we envision 40, 50, 60 years out that, we're still going to have growth? I'm sort of the view that, look, what's growth? That means we have better software, we have better education, better healthcare. Is there a reason that won't keep improving? I don't see that. But I guess what I'd say is, in a certain sense, to try and have that argument today, we're kind of arguing in an area we don't know anything about, because I don't know what the world will look like in 50 years. None of us really does. I mean, you go back to when I was a kid, I was watching Star Trek. It was supposed to be the world in, the 21st century, 22nd century. People see the original Star Trek, what the computers look like. We're not very good at seeing into the future. So I was having this big debate, 50 years from now, will we be able to have growth? I kind of think we will, but I don't really think it, at this point, we're really not, we don't have anything sensible to say about that.
Fair enough. So my final question here is, despite Republican claims that the media has a liberal bias, which is, they're kind of working the rest continually, on economic matters, it's clearly the opposite. That the mainstream media, traditional media in America, just has an incredible conservative bias on economics. And you point this out continually, especially their view of Europe and austerity, and even just the U.S., some of the stuff that you're talking about is common sense things that just never get a mention. What do you think's going on? Why do you think the media here has such a conservative bias on economics?
Well, I think both, that the economics profession has a conservative bias. I mean, you do have liberal progressive economists, and they're growing in the profession, but they're still a minority. So I think it's the profession's a bias. The people own the media, obviously if you own a newspaper, you're wealthy, you're anxious to see people challenge your views. So I think there's that. And then there's an enormous amount of inertia. Reporters, and even the best reporters, I've gotten to know a lot of reporters pretty well over the years. These are people with the major news outlets, the Washington Post, the New York Times, National Public Radio. They aren't anxious to stick their neck out. And I mean, it's just cowardice. It's just like, okay, I'm doing what everyone else does. That's my job. So you go, oh, but maybe everyone else is wrong. And I'll give you a very specific example. As the housing bubble was growing, 2002 to 2007, I was saying, this is a problem here. It's a problem here. And I tried to, prod people, including many reporters I knew, and they'd listen to me. They'd be polite, but they go, well, no one else is saying that. So it's, the structure of the profession, reporters, the journalism profession is really tilted towards not sort of stepping outside of what everyone else is doing. So there's very few reporters that are willing to do that, even at the top publications. So I'm not looking at someone at a small town newspaper, I understand that, but the reporter at the New York Times has the time, in principle, to do that. But they're very, very reluctant to sort of break new ground because, they just see that as very dangerous.
Interesting. All right, well, let's open up the questions. A little request here is keep the 2 questions. We don't want monologues. I will come in with my New York and cut people off here. So questions? Yes.
Yeah, with respect to Medicare for All, what's the response to the position that over 100 million are privately insured at present, and the overwhelming majority of them are happy with their commercial plans, and would resist with their last ounce of effort any attempt to put them into the Medicare program?
Well, there's a couple responses that people make. One is that, if you look at polling on Medicare for All, it actually is very supportive. Even Republicans, who find like half say they'll support it. I don't find that polling very convincing because I think for most people they're not clear what that means. So they don't, so then you say, oh, take away your private insurer. The somewhat more sophisticated response is, oh, when people are explained, when we explain it to them that they're going to have insurance that's even better, then they'll be supportive. And, my view is that it's going to be very, very hard to convince people of that. And it may not be true in many cases. So one of the points I make, and I should say, I've worked with Medicare for All people. There's a lot of very dedicated people who devoted years and years of their life to this. So they're very committed, very hardworking people. They want to make claims that you go, okay, suppose you actually got your way, and this is, you were talking about this before, Jason, okay, so we're going to filibuster. How do you get through the filibuster? Can you somehow get this in reconciliation? We don't even know Democrats will control the Senate, but let's say somehow that happens. Well, are you going to require that all doctors be in the system? And they all go, yes, the Medicare for All people go. Do you think there's a prayer in earth that this Supreme Court will uphold that? So in other words, so one of the issues, if you recall back with the Obamacare plan, Obama said, you like your doctor, you can keep your doctor. You like your plan, you can keep your plan. Well, in all cases, well, they got rid of some plans. There was this huge outcry. Now, I think a lot of it was orchestrated because most of those plans were very short-term plans. So you're on a plan for 6 months and you didn't renew it, you probably weren't going to renew it anyhow. But in any case, it became this big issue. Well, a lot of doctors aren't going to go in the system. Now, we might want them. Our Medicare for All people might want that. But the idea that the courts will uphold it, I think it's almost zero. And I've talked to some serious legal scholars in this. And it's not a question of what we are reading in the Constitution. It's just what do we think this court will do? And no one thinks that this court will say that a law that says doctors have to be in the Medicare system. Even in the UK, where they have a national health care system, they can work outside the system. They have a private. So what that means is you can't tell someone truthfully they can keep their doctor because you don't know that. Their doctor may opt out. So when we get back to the private plans, can we assure them that this plan will be at least as good as the private plan? Well, in most cases it probably will be, but in some cases it probably won't be. So I think you have a really big cliff to overcome.
Dean, when you talked about getting rid of barriers to doctors coming in, that's a great idea. But there's another barrier you could get rid of on the drug side. The 1962 Co-Founder Amendment said they've got to test for efficacy, and that's the thing that added years to the cost and hundreds of millions to the cost. What about get rid of that requirement? We get drugs a lot sooner.
I've had a lot of asks. So the specific point, the FDA tests for both safety and efficacy. So everyone could agree we want them to test for safety. Almost everyone. Very strong libertarians here, but you want to know that if you're getting a drug, it's safe. So the question is, does the FDA also have to determine that's effective? And I guess I would be reluctant to get rid of that as long as you had the patent system, because basically the patent system gives them a really big incentive to lie. They do it all the time. There was a recent suit initiated, I think it was by Massachusetts Attorney General against Purdue over marketing of OxyContin. And the suit alleges that they were marketing it, claiming that it wasn't addictive when they knew full well that it was. And you have cases like this all the time. Vioxx was a famous one that was marketed by Merck, where they had evidence, or at least it was alleged, they paid a lot of money in the settlement. I can't vouch for what's true and what isn't, but in any case, they paid a lot of money in the settlement that they had evidence that Vioxx was harmful. Vioxx, for people who know, is arthritis drug. It was a pain reliever primarily designed for arthritis. That it was harmful for people with heart conditions. They increased the risk of stroke and heart attack. Well, naturally, there's a lot of overlap between people who suffer from arthritis and people who suffer from heart conditions. So this is the sort of thing that they should have informed the public about, and they didn't. You have an enormous incentive to lie when you could sell a drug for prices that are way above your cost of production. So if we envision a world where we got rid of all patents and all these drugs were selling at the free market price, they're selling, like cups and shovels, and they're making normal profit, nothing more, then I'd be okay with that, because, you know, again, they might try and market it, but there's not so much incentive to lie. But as long as you have that enormous incentive, I want the FDA saying, yeah, this is also effective.
I'm curious, the impact of demographics on your predictions and things like that. Have you factored in changes in demographics?
Sure, well, these are from the Congressional Budget Office, and this is, you know, this is something that, you know, again, I was talking about when I first came to DC in '92, and everyone was going about, oh my God, the baby boomers are gonna start retiring, and it's gonna be a huge thing. Well, yeah, that does make things worse. I mean, you have all these people that have been in the working population, now they're getting Social Security, they're getting Medicare, so it definitely raises the cost. And you know, there's nothing, you know, I always say there's nothing really you can do about that. Well, baby boomers now semi-retired or whatever, you know, don't expect this, at least I'm not gonna volunteer to be killed off. But it's a factor, but just not that big a factor. So yeah, I think people hugely overplayed that.
You didn't mention preventive medicine at all, either as a cost container or as what lies ahead in the future. Can you just give us a little color on that?
Yeah, you know, I do think it's very important, and you know, one of the issues when you look at health outcomes, the U.S. is horrible. So, you know, life expectancy, infant mortality, you know, a number of other outcomes, and a lot of that is, you know, poverty. I mean, you know, people in poverty tend to be in poor health. You know, obviously causation goes both ways. You know, if you're in poor health, you often can't work, and not being able to work in the U.S. pretty much means you're going to be in poverty, or you can't work full time. But, you know, if we could do something about people's living conditions, that's likely to have a huge impact on health outcomes. And, you know, this is, a lot of this stuff is very cheap, very simple, and, you know, it's hard, it's one of these things where there's no real lobby for it because there's no money in it. And, you know, the story I like to tell, the good story, is how successful we've been in beating back tobacco. And, you know, I've looked for this, maybe someone knows that there's good account of this, but it is really kind of an amazing story, because the tobacco industry was incredibly powerful. And, you know, look, we're sitting around this room, what would happen if someone started smoking here? Well, you shouldn't laugh. When I was in college, which is not ancient history, someone would have been smoking. You would have had ashtrays. That was just standard. People smoked in classrooms, they smoked in restaurants, they smoked in airplanes. You know,
I remember that.
that's not ancient history, but they were beaten back. And, you know, it was obviously a lot of work by a lot of people. I'm willing to bet most of them were women, but, you know, I don't know the account. Someone has to write that up. But that was a great, great public health victory. And, you know, people have tried, you know, Michelle Obama was trying to do this, you know, was a first lady do? I mean, I just assumed the first lady, first spouse not be in the picture, but nonetheless, we had this thing we're supposed to be in the picture. She was trying to promote exercise and, you know, some good eating, and, you know, she got all this flack for it, but that would make a huge difference. And, you know, one of the things, you know, some people have proposed, I don't know how many states have done this now, states or cities, but a Coke tax, soda tax, I guess, in most parts of the country. I was originally opposed to that because it's likely to be regressive, but it strikes me the health benefits of that are so large that, you know, it would be worth doing. So, you know, if you did some very simple things, I think they can go a long way. And yeah, you know, I wish we would do more of that, but it's not, there is no money there. I should also point out that part of the story, you know, if we went my route, you know, put me in charge here, and said, okay, you're going to finance research. Well, part of the story would be, you know, you'd spend on preventive research, you know, research into prevention. And as it stands now, you know, let's say, you know, one of the big drug companies is doing research in particular area of cancer, and they find, you know, we've been getting interesting results. It turns out if you eat, you know, this type of vegetable, you know, some type of vitamin, it drastically reduces your risk of getting it. Now, they might make that public, you know, but they have no particular incentive to do that. They're not going to get any money off that. So, you know, what do? You know, maybe they make it public, maybe they just go, oh, that's interesting, you know, keep it filed away. But if you're giving the money financing research up front, you know, and it turns out, you know, okay, you gave all this money to, you know, this company and it was doing research on drugs, they didn't find any drugs, but they found all these great prevent. Well, give them to them again, you know, so you don't care about getting the drug, you care about health. So if you did all this research and it had huge health benefits, but no drugs, well, so what? You know, but where we stand now, there's no money in it.
And how do you factor in millennials who are outnumbering the baby boomers into the healthcare when they are expecting government to take care of them and tend to favor more of a Medicare for all. And that's and making the population even bigger and requiring government to supply healthcare to them.
Yeah, well, it's a really good question. I mean, polling data shows now that, millennials are much more liberal in economic issues, liberal left than like. And, they also favor, there's a lot of support for a Green New Deal, so aggressive actions on the environment. That will be a big factor. Now, how far that goes politically, at least in the immediate future, is hard to say. So I think a lot of people overestimate that you have people like Alexandria Ocasio-Cortez, very dynamic young congresswoman from New York. She can get elected there. Can someone like her get elected in Iowa? My guess is no. But I think that is a major force. It's shifted the debate. But, are they going to be able to push for a Medicare for all that's, say something like Bernie Sanders is proposing? I mean, they're able to push for it, but they're not going to get that. That's the way I see it. So I guess my view is I'm really glad that you have a lot of millennials out there pushing for these things, because it does move the debate. The likelihood that they'll get the agenda that they want, I think, is close to zero, but it does push the debate. The other point that I'll just make, being old enough here, that there was a lot of talk of generational change when I was young, in the 60s, that things were going to change the 60s generation, flower children, anti-war protests. It never happened. So, what happened was a lot of those people changed. So what will happen with the millennials as they get older, I don't know. But, I've heard this story before.
I'm going to go with the theme of you having a lot of authority to make changes. So, let me ask in two questions for you. If you did have the authority to change us much closer to the German system, now you did it for economic reasons, but let's say we have a better system, what would you do? What would be the first 3 or 4 things that would actually get us into that direction?
You mean the healthcare system or the
Healthcare system. Yeah, not to be German.
We have to lose our sense of humor. Well, certainly, controlling drug prices, I would go both routes. That, one, having negotiating drug prices, and 2, the, funding research in, certain areas. That won't pay off right away, as people point out to me. It takes a long time, so it's not until next year we would have, the new drugs developed. But it might not be that long, because you could buy up research in progress. You don't have to start from ground zero. So that would be one thing. Same story with medical equipment, by the way. It's the exact same story. So, when you have MRIs costing $3,000, $4,000, it costs a tenth that in France. This is totally, because there's no control. It's a monopoly, no control of the market. So do that with drugs and medical equipment. The doctors, opening it up to, foreign physicians, bringing down the pay for doctors, so I do that. And reining in insurers, that is possible. I just flashed through that quickly, but part of the story of the Affordable Care Act, and we did a little bit of this, but basically it does give a mechanism where you can control the insurers. So one of the things in the Affordable Care Act is that there's a requirement, they use this term medical loss ratio, which means what % of the collected premium has to be paid out in benefits. And it has to be at least 80%. So you have to pay out at least 80% of what you take in the premium. You can make that 85%. You don't do it overnight, but you could raise that, and some insurers will go out of business. That's the way a market works, but that would make them more efficient. So you could rein them in that way. So that would be part of the story. The other part, and this gets into an area I don't know in great detail, but I do think it is important, is more standardization. So even if we can't, overnight get to single payer, what we can try to do is say, okay, you guys can still compete, the insurers can still compete, but here's what we want the deal to be. Here's what the policy is going to look like. So they're much more narrowly constrained. So you won't have this story that, this insurer doesn't, you have a big copay for cancer, but not for heart disease, and vice versa. If you try to talk to someone and say, people like choice, you go, do you know anyone in their right mind who wants to read through policies? I'm an economist, and I don't want to. You take your average person who has a day job, that's a totally different area. They don't want to be. It's absolutely nuts. So if you very much narrow narrow, the differences that ensure between policies, I think that would be, would benefit everyone. I mean, it'd be better for patients and also just eliminate a huge amount of needless waste.
Other questions? Yeah.
Yeah, so I have two questions. First is that how do you see immigrants and also international students fit into this picture? Because we're in California, and there's a huge influx of tech workers to the Bay Area, and most of them are young and healthy. And also international students, when they come here, they're required to pay into the healthcare system. Also, most of them are young and healthy. And then the second question is, last summer, NYU Medical School announced that it will cover tuition for all students. And then following that, we saw a surge in applications to NYU Medical School. So what's our interpretation of the significance of that? Do you think it's a starting of a change?
Yeah. In terms of immigrants coming here, I don't know that that huge a factor. I mean, we've had this big issue with the undocumented population, which, the outstanding population is quite large. Obviously somewhere in the order of 11 million, whether those people get coverage or not, it's a big issue. Do they pay in? I mean, to my view, the obvious logic there was actually bipartisan support, a few years ago for immigration reform that involved the path of legalization. Had you done that, presumably people would be getting health care along that path, at least, the same sort of care they get through the Affordable Care Act, and that would mean they're covered. I don't know the net effect. I mean, you have more people paying into the system, more people getting benefits. My guess is that the net effect would be fairly limited. But as a general rule, I mean, I would like us to ease up the rules that, where you have people that are studying here, that they have more options to stay here. Part of that's, well, it's at this point moot self-interest, but my wife was an immigrant, and, she's now a citizen, but, we did have issues that she might have to go back to her home country. So, but I am sympathetic to the idea. I mean, which isn't to say, I have always people going, you want open immigration? No, but, we could be a little looser, and we would not suffer for allowing more foreign students to stay here. The story at NYU, I think, is a great story. So, the point here, people didn't hear, I forget who the billionaire was who put up the money. In any case, some billionaire said, I'm going to pay for NYU medical school to be tuition free. So, that means people can go through med school and come out with zero debt. I mean, they're not debt from their college, undergrad, but they won't have this huge debt because typically it's much more than undergrad. And yeah, no, I do think that's a good model. And, I'd love to see, again, it's part of the larger reform in the healthcare system, because my biggest concern isn't that doctors have this huge debt, but if we're going to get their pay down to, sort of world levels, or at least rich country levels, it does make sense that they not come out with this big medical debt. And, that is an issue. I mean, there's no doubt about it. You might say, and I was being a little cryptic a moment ago, that, okay, you have debt, $250,000, $300,000, you're going to be earning $250,000, $300,000 a year over your life. That's not a big deal. But I certainly could understand, particularly someone who's not from a wealthy family, they have sort of debt, and they freak out over that. So they go, oh yeah, I can't work in the public health system, I have to go work in private practice and earn this really big money because I have this huge debt. And again, I could sit there as an economist and go, come on, you don't have to earn, you could earn $150,000 a year paid off just fine. But I can certainly understand someone being freaked out with that. And so I think it's best not to put people in that situation.
In some of the European countries, you have your medical school paid for and you're a civil servant when you get out. So you'll never have a high income. You're basically a government worker. Do you think that's an idea that we should experiment with in certain segments?
Well, you already have some programs where you have debt forgiveness if you go work in underserved areas. So you have people that go work in Indian reservations or rural areas that have severe doctor shortages. I think there's some inner city areas that qualify as well. So if you're willing to work there for, I don't know the exact terms, whether it's 5 years, 10 years, but you spend a period of time in these underserved areas. So I think it's a very limited measure, but I think that's good, and can you phase that up, so that you eventually get to the point where you have, most doctors that are, doing some sort of, what we might think of as public service at a lower pay and having their debt relieved. You could certainly ramp that up. I don't know if that's get you to the story where doctors are paid more like West Europe than they are here. But I think certainly ramping that up is one way to, one way to look to.
I think it was about a year ago with great fanfare, Berkshire Hathaway and JP Morgan and Amazon announced they were going to revolutionize healthcare insurance. Then I heard nothing more. Have you been following that, or has it gotten any traction?
It's a very good question. For people that didn't hear about this, this got huge play, Amazon, Berkshire Hathaway, and who was the third one?
JP Morgan.
JP Morgan, yeah. So these are very big actors, and of course, Amazon and Berkshire Hathaway both having very good. Berkshire Hathaway is Warren Buffett, so both having very good reputations in their area. So the idea was that they were going to, enter health insurance market and really revolutionize it. And they got, I'm forgetting the guy's name, but he also is a health expert. He was in the Clinton administration, writes for the New Yorker. I'm just drawing a blank. He's a Harvard professor of public health, but he's heading it up. And everyone thought, oh my God, this is going to be a huge deal. I don't know where that stands. I don't think it's up and running yet. Maybe they're not rushing into it, which is probably a good thing, because again, if I were them, I wouldn't want to rush into it and then fall flat on my face. So they might be taking the time to really make sure that whatever they do put in place works well. You could hope for all sorts of good things. I wish I could remember the guy's name.
Atul Gawande.
Yeah, Atul Gawande. Who's he's health policy at Harvard. I forget the exact area, but he's in any case he was in the Clinton administration working on their bill, obviously, working in their healthcare plan, and then he's been writing a lot and been at Harvard, and he's a thoughtful guy. So if he's in charge of it, I would trust that he would at least not make the stupid obvious mistakes, which doesn't mean that he's not going to make some mistakes, but he's a thoughtful guy. So in principle, it could be very innovative. I mean, that's one benefit of starting something like that from scratch, is it's always hard to change something that's in place. If you're starting from scratch, you in principle have a lot of leeway, and clearly the capital at JP Morgan and Amazon and Berkshire Hathaway. So, in principle, they can make a very big wave, but to date, I just don't know. I don't know where it stands. I don't think it's up and running yet.
Other questions?
I can't quite understand well, let me ask you about the provision of medical services and hospitals and the recent, I'd say the last 50, 20 years of the large agglomeration of hospitals into large corporate structures and taking over lots of the local hospitals and either improving or worsening the service. But when I got some surgery done and I looked at the bill and then looked at some of the unbelievable expenses, or if you get a bill from an emergency room and you realize that the unbelievable cost of this, and it's all turned over to my insurance, how is it that the third-party payment system just doesn't seem to be able to negotiate better prices? And these are big insurance companies, really sophisticated guys, even really big, sophisticated corporate structures that are providing medical services, and in any other business, you seem to get much more what would appear to me to be market prices. But in this case, that just doesn't seem to be the case. So $5,000, going in for some minor things in an emergency room, and you walk out with a $5,000 bill. How is it that those prices that get negotiated by these large, sophisticated players aren't brought down to what would appear to be a more market level price?
Yeah, it's a really good question. I mean, part of it is, it's been this dynamic where there's been concentration on both sides. So among the providers, you have hospitals buying each other up, buying up doctors' practices. So there's clearly been a lot of concentration there. And then on the insurer side, you've had a lot of big mergers of insurers. And the Obama administration's position was they're very sympathetic, actually, to most of the mergers of insurers, with the argument that that was going to put downward pressure on the prices of the providers. The evidence for that is very limited at this point. So my guess, and this is not having tried to study it at any length, but my guess is what's going on is that the insurers, you know, at the end of the day, your ability to negotiate is your ability to walk away. So can, you know, even a big insurer, an Aetna, United Health, can they tell, you know, the major hospital chain in this area that, okay, you know, that price isn't acceptable, we're not dealing with you. And I think for most of them, that's something they're not prepared to do, because they have to, they can't have a situation where, you know, a large share of their patients are going to, you have to tell them you can't go to the major provider in that area. So I think that's what it comes down to. So if you know, my view is if you're going to have, you know, a lot of mergers on one side, it would be on the insurer side and regulate them, and limit the mergers on the hospital provider side. As it is, we seem to have done neither. I mean, you see, you know, I'm not going to say none of the mergers were ever turned down, but, you know, most of them seem to fly through, and, you know, they're perfectly content with situations where you could have a single provider having, you know, 30, 40, 50% of the market in a given metropolitan area. And, you know, if you have that, you know, even the biggest insurer, I don't think they want to be in a situation where they, you know, tell the people in that area, oh, you can't go to the major provider. So I think that's where you end up with that problem.
All right, I think our final question here, yeah.
The previous question person mentioned like $5,000 to go to the emergency. What is causing these high costs to go to emergency room, like something like that? What's initiating that?
Yeah, you know, I think everything in the medical chain is overpriced. And, you know, again, patents are a really big part of it. They aren't the whole story, but they are a really big part of it. And, you know, I think part of it too is that, you know, because I've had people point out, you know, this generic drug, it's off patent, so it's not. Well, part of it is that you're used to paying a lot for drugs. So if, you know, all drug, if you didn't have patented drugs, you didn't have drugs that sold for $300,000, they sold for $500,000, $1,000, then you could have a Shikeli come in there and start charging $5,000, $8,000. But I think you get everything inflated. And it's a sort of situation, people aren't doing comparative shopping. So it's, you know, whether, I mean, it might sound cryptic, but I'm serious. I mean, you know, if I'm gonna go to coffee, you know, I might pay 25 cents more, but, you know, if there's a place I know it charges me $2 more than the place right down the street, I'll go to the place right down the street. Most people will. You know, with your hospital, okay, you have to get surgery. This is where your doctor sends you. You're not going to shop around. There's very few people who will. In fact, someone did a study recently. It was fascinating. It was for, I can't remember what the procedure was, but the point was it was very much a routinized, non-emergency procedure. So there's no reason to think that, you know, place A was better than place B. I wish I could remember what it was, but it was something you'd agree. It was, you know, very routinized. You know, and people overwhelmingly went to the place recommended by their doctor, and they did nothing by way of shopping around. So people just don't do that with their health care. We might say that's bad, they should do it, but they don't. So what that means is, you know, no one pays attention if, you know, this item is twice as much as it should be. You just don't have the cost pressure, you know, the pressure on the other side. So
Well, I was talking in reference to an emergency situation when you gotta go in here. That all of a sudden you've got a huge bill for doing that. You know, are they maybe upcharging the emergency to cover other expenses they got somewhere else in the building?
yeah, I mean, they're basically gonna, you know, the specific service you're getting tends to bear very low relationship to what you're actually paying. So they're gonna charge whatever they can get away with for that, you know, for that service. And if there's no one policing it, so there's no one on the other side saying, wait a second, no, this should have only cost, you know, $500, not $3,000. There's no one saying that, they're gonna put down $3,000. The other game that they routinely play is changing the coding. This is why it gets so difficult. So they know that, you know, if you came in there with condition X, then they're only gonna get 500, but if you came in with condition Y, then get 3,000. Well, they'll put down condition Y. And it's very, very hard to police that, because who's going to oversee that? Go, wait a second, no, that's not what the person had. I know people who've, you know, been in that situation where they coded it one way, and that's not what I came in with, and they have big fights, and usually if it's insurer paying at the end of the day anyhow, they don't care. So they have very little interest in it, but, who's in a position to say, you put down the wrong code here?
All right, well, on that cheery note, I think, yeah, we gotta wrap up here. Let's give Dr. Baker a big round.